Okay, so let's talk first about screening. So, want to make sure everyone's first clear about the differences between suicide risk screening versus suicide risk assessment. So, screening's the procedure where there's a standardized instrument or a protocol, and we use it to identify individuals who may be at risk for suicide. So this can be done independently. So as a school social worker, let's say you're in your office and you're not sure if there's a certain student is at risk, you can do this screening with them in your office, or you can do it in like what my kids' school just did recently. They did it as part of a bigger program where they did it for the entire 7th grade class. So there's really a ton of different ways you can use these screeners. Okay. They can be done orally, where you actually ask them the questions that are on the screener, or you can do it by giving it to them and they can check boxes. It's a lot of times it's computerized as well. So that's screening. Now so when you screen, you're identifying who may be at risk. Okay. But the suicide risk assessment is a more comprehensive evaluation done by a clinician to assess for suicide risk, estimate the danger to the patient may be used interchangeably because I use patient, client, student, individual kind of interchangeably because it really depends on the different situation when you may or may not use them. But at the end of the day, I always refer to people how they prefer to be referred to. Some prefer patient, some prefer client, some prefer individual. And I really just go by what they prefer. But I will use them interchangeably in this presentation. And ultimately with the suicide risk assessment, after you look at the risk, you want to decide on a course of treatment, or if within the school social work area, you want to determine, okay, what are the next steps? What needs to happen next for the student? And an assessment can involve more structured questionnaires, and it can also be more of an open-ended conversation with your student, and oftentimes their family, to gain more insight into their thoughts and behaviors, other risk factors, protective factors, as well as their medical and mental health history. There's the Suicide Prevention Resource Center too. I put that at the end. This is where they kind of talk a little bit about the differences between screening and assessment, but I think it's a really helpful a website to take a look at. And actually, Shelby Rowe has just been named the new director, and she's amazing, and I'm really glad because she's wonderful. Okay, so this is the ASQ. This is this one is good for teens and youth. It's been tested a lot with the youth population, but I'll explain to you and maybe demonstrate to you how it might work. Okay, so let's say you're concerned about, either a teacher has said to you, I'm worried about this kid. One of the other students said that they're, said something about suicide online. I don't know what's going on. You can do a screener with this kid. So you could either do it in the office, you could do it, and find some other way. It really depends on your position, and your school and how you all do it. And feel free to ask specific questions about this too, especially if you have specific cases where you're not sure how and when to use it. That would be a great thing to kind of put up in the Q&A, so this might feel a little more relatable. But you start by asking the first question, which is, have you ever wished you were dead or wished you could go to sleep and not wake up? So you want to ask them this, and if they answer, and you want to make sure they're answering for the past month, and if they answer yes, then you always ask question 2, regardless if they say yes or no. Then you want to move on to question 2, which is asking more directly, have you actually had any thoughts of killing yourself? And you want to make sure you're using the words killing yourself. You don't want to say hurting yourself, because that means something different. You want to feel and for some of the school social workers on here who maybe aren't as comfortable, maybe you didn't get as much suicide related training in where you went to school, or maybe this is new to you, or maybe it's just an area for you that feels uncomfortable, that feels difficult. I really urge you to practice doing this. Practice doing this with your colleagues. Practice doing this screening together. Practice it on your own. I always tell my students that I teach, like, if you're worried talking about suicide, start doing it while you're taking a shower. Start just saying it out loud. And so you're getting used to it, that it's not this dirty word we can't say. Because the fact of the matter is, kids are killing themselves every day, and we need to be able to talk about it. So if they answer yes to either questions 1 or 2, then you ask questions 3, 4, 5, and 6. If they say no to 2, so if they haven't had any thoughts of killing themselves in the past month, you then skip to 6. Okay. And 6 is the question of, have you ever done anything, started to do anything, or prepared to do anything to end your life? So that's basically asking about past, past history. Okay. And if they say yes, that indicates that there's a high risk, because what we know about risk factors for suicide is that any previous suicide attempt puts them at greater risk of a future attempt. It's a huge risk factor that we want to pay attention to, even if in the moment they're saying that they're not feeling suicidal. Okay, so questions 3 through 5 are getting at this idea of plan, intent, and access. Okay. Number 3, have you been thinking about how you might do this? And if they're like, what do you mean? You could say like, you could say things like, so like, have you think how you might try to kill yourself, a way that you might try to do this. And so that's what you're trying to get on. Like a kid might say, I thought about taking an overdose, but I never made a specific plan as to when, where, or how I would actually do it. Okay. And so then you do a check mark if they say yes or no. Then the 4th one, have you had these thoughts and had some intention of acting on them? Now, not all kids will understand what intention means, especially if you're doing this for like a 5th grader. Okay. I like saying, and I'll talk about this later on when we talk about assessment, but you could say like, have you had, do you feel like this is something you might actually do? Okay. That would, if they say yes, then that would, imply intent. Have you started to work out or worked out the details of how to kill yourself? Did you intend to carry out this plan? So you want to ask that question too, to them. So you want to get at those 3 things. And if the whole point of the screener is, if they're in the red, that indicates high risk, orange is moderate, and yellow is low. So here's how this looks. Okay. And then there's also this, if they answer yes to any of the above, you want to ask the following acuity question. Are you having thoughts of killing yourself right now? Because what this question does, and this was added in, this ASQ, this was added into this later on, because it wanted to get at this in the moment suicide risk. Like, are they feeling it right now? Because as we know, suicidal thoughts are fleeting. So we want to see if they're feeling it in the moment. And then what is great that they developed for this ASQ is they see this next steps column. They talk to you about what to do. So if a patient answers no, then you're done with questions 1 through 4, then the screening's complete. Okay, you don't even need to ask question 5. If the patient answers yes to any of the questions 1 through 4, or refuses to answer, they are considered a positive screen. So then you would ask question 5, this, are you having thoughts of killing yourself right now, to assess for acuity. So this is how this has developed, this screener here. And this is something that if you Google it, ASQ, you can get it, because it's developed by NIMH, so it's publicly available. Okay, and it's been tested multiple times. So I'd lean towards this one for a youth population to use. There is also another one called the, I apologize, this is the Columbia Suicide Severity Rating Scale right here. This is a great one, but it's a little more involved. The ASQ is something that I think for schools, I may recommend this one, especially because I really like what it has for the next steps area. But I think so typically ASQ is being used in a lot of schools. CSSRS, excellent. They're both excellent, but I see this used more in hospitals. But what to know is they're both validated rating scales to use with youth. Okay. Screeners. Okay. So now I'm going to click on the Q&A and see if there's any more screening related questions. Okay. So just access the ASQ. Google, you can Google it and you'll be able to get it. Good question about what ages is the ASQ normed for. I apologize. I don't know that answer. I can almost guarantee on the NIMH website, it will say that. So I apologize that I don't know. I know they use it for young, like I want to say, I think it's 11 on. I'm not positive though, so please don't take, please don't take my word for that until we double check the NIMH website. But I'm pretty sure they've used it as young as 11. Okay. All right. I'm the clinical supervisor for National Runaway Safe Line, a crisis hotline for runaway and homeless youth. We talk to many youth with suicidal ideation, history, etc. Based on this research, what do you suggest is the best way to assess youth in a one contact situation? I'm not quite sure what a one contact situation is, but I'm going to guess what that means is you're one-on-one with the teen. And if you're talking about runaway and homeless youth, I would, I think the key with this is giving them an opportunity to just talk and just for you to just be there and just listen to what they have to say. And I think you'll need to do what I'm going to talk about suicide risk assessment right now, Stephanie. So I think this will be a good segue into this, but I think you're going to want to use this safety card, which you'll see, which is what I would recommend you do in this kind of situation. Oh, good. I'm seeing a lot of questions here that are about assessment. So what I'm going to do now is I'm going to go into assessment because I'm going to talk about, and I'm going to talk about assessment next. And like this question, if a youth denies they have suicidal ideation, you still ask about a plan. I'm going to talk about all that right now. So I'm going to move forward here. Okay. So let's see. Suicide risk assessment. Okay. So the key with the suicide risk assessment, so again, we're trying to determine level of risk and what to do, okay? This must be done as a part of a thorough biopsychosocial evaluation because you can really only assess for suicide in context. You can't, like a screener isn't enough. A screener is just to show you, okay, do we need to do an assessment now, okay? With youth, it's really important whenever possible that you also talk with the parents. Now, that's not always possible. I understand it, especially with Stephanie's case that she's talked about with the runaway youth. It may not be possible for them. And it may even be contraindicated in a lot of places, especially if there's abuse or something like that going on in the home where the parents are one of the main contributing factors to the child's suicidality. But if we are in a situation where we're lucky enough to have both teen and parent there, we want to make sure we're doing separate interviews, not doing it all together. My usual rule of thumb, and of course we'll change this up a bit depending on some things, but I typically like to do if the kid's 12 or younger, usually like under 12, depending on how they seem to be, I usually like to do the interview with the parent first and the kid second. But when the kid's like 12 or 13 or older, I usually like to do it with the kid first and then the parent second. And the reason for this is with a teen, you really want to gain rapport. You want to make sure that they don't think you're just there as part of your parents trying to, do what they want you to do. You really need to gain their trust. And I think it's often easier to do that by starting with the teen and hearing from them what their story is. With a kid, it's a little bit different because like a younger kid, like under 11 and under, because they're used to this, your parent, talking to the parents first type of thing, especially with doctors and that sort of situation. So oftentimes it's easier to get the information from the parents first. And often too, when you get the information from the parents, okay, well, I should say this, when you do an assessment with a kid around 10 years old, they don't always know everything to bring to you in the conversation. So you often have to ask more closed-ended questions along the way than when you're with a teenager where you're asking many more open-ended questions to elicit their responses. So oftentimes a kid will total it, 10-year-old will just, you ask what, how they're doing, what's going on, nothing good, short answer to their questions, unless you ask them specifically about maybe something happened in school where they scribbled something on their notebook about, I want to kill myself. You will if it's a younger kid, you're going to need to ask them specifically about those things. So it's often more helpful to meet with the parent first. Okay. Moving on, suicide risk assessments ask very specific questions to elicit very specific information. And we're going to go over those types of questions that need to be asked. And if the teen answers no to every question you ask, you're going to need to change your approach. And we can talk a little more about that too. So suicide risk assessments are on their current they're based on their current symptoms and the level of acuity of those symptoms. We also want to look at past history, risk factors that may be present, protective factors that may be present, how well their family's functioning and how flexible and adaptable they are, and as well as at the end of the day, you have to use your own clinical judgment. If you leave a suicide risk assessment feeling like a lump in your throat, or like that, just your gut feeling being like something doesn't feel right, you need to listen to that. I like this one as a guide kind of to what to do during a suicide risk assessment. The first being identifying risk factors, second, identifying protective factors, third, conducting suicide inquiry, and fourth, determining risk level or intervention. And then, of course, the fifth, documentation, which is absolutely critical, especially, in a school, if you're doing an assessment in a school. And I realize that some of you as school social workers will never be doing an actual assessment in the school. And that's okay. You may always only do a screen, and your school may say you need to refer out for an evaluation. Okay, you may not be able to do it, but there are some schools where you are the one doing it. So it really kind of depends. So it's so important that you know what your role is and what your rules are within your institution. But even if your school says you can never do a suicide risk assessment, you as a social work clinician need to know how to do one. It's absolutely imperative. It will come up for you at some point in your life. It's such a critical skill to know how to do. We're doing a disservice to all the youth we work with if we don't know how to do one. So I really hope that even if it's not necessarily in your, the roles and responsibilities of your job, I hope that you take away from this the ability to do it, because I really do believe that anyone can do this. Okay, let's talk about risk factors. You want to ask about current or past diagnoses, whether they're mood disorders, psychotic disorders, bipolar, substance use, eating, anxiety, trauma, personality. There's a wide variety of diagnoses that put adolescents at risk for suicidal thoughts. You want to ask about key symptoms. Anhedonia. Are they not as interested in things as they used to be? Are they impulsive? Are they feeling hopeless? Are they experiencing panic? Are they not sleeping? Insomnia is a huge risk factor for suicide. Are they experiencing command hallucinations where they're hearing a voice telling them to kill themselves? These are things we want to be asking about. Suicidal behaviors, what we want to ask about there are, have there been prior attempts? Have they ever attempted suicide before? Have they ever tried to kill themselves before in their life? Have they ever aborted attempts? Means have they ever been about to try to kill themselves but stopped themselves? In interrupted attempts means, have you ever tried to kill yourself but somebody else stopped you? Okay. Non-suicidal self-injury is another really big risk factor that I want to talk about for just a second, because it's becoming so common among our youth, non-suicidal self-injury. So we need to understand the relationship between NSSI and suicide. Not all kids who self-harm want to kill themselves, but what self-harm does is it habituates the individual to pain over time. And this, as Joiner's theory, I talked about it earlier, how Joiner posits that it's this combined, thwarted belongingness and burdensomeness together that combines for suicidal desire. What he then postulates that actually propels one from ideation to action, one from actual thinking about suicide to actually dying by suicide, is something called capability, suicide capability. So how you gain the ability to, in this theory, is by a lot of exposures to painful experiences that ultimately habituate you to pain over time. So you gain this fearlessness of death. Okay, so that is really for NSSI. That's kind of your understand. That I hope it helps you understand a little bit why it's a risk factor. But we could do a whole talk on NSSI, because it is an extremely complex phenomenon, especially in its relation to suicide. but you always want to assess for it because it is a risk factor. Family history of suicide, we do know that there is familial transmission of suicide, which is extremely concerning. So if you know that one of your students, parents, or someone in their family has died by suicide, that's an important thing to be aware of. If the individual themselves has any prior attempts, hospitalizations for suicidal events, or any sort of family history of psychiatric diagnoses too, you want to be aware of this as a risk factor. Other precipitating factors, these are like triggering events that might lead to the individual feeling humiliation, shame, or despair. Okay, ongoing medical illness is another thing that you want to pay attention to. Bullying, things on social media, breakups, things like that, you want to be aware of. Again, not because they are the reason why a kid kills themselves, but because they are contributing factors. Identifying as LGBTQ+ is a risk factor to be aware of, as well as substance use, and of course, access to firearms, which we'll talk about more in a moment. Protective factors, this is, I feel like, often skimmed over a lot, but it's such a critical piece, is you want to really be able to identify what are some things that are protective for this teen. Are they, for instance, do they have internal protective factors like having an ability to cope with stressful things? Are there religious beliefs that may be at play that are really important to them, that are protective? Do they have a high frustration tolerance? Are they able to, are they able to have emotion regulation skills, like kind of like what I was talking about earlier, which are things we need to be teaching our kids? Are they pretty good with that? If so, that's huge. It's a huge protective factor. There are also external protective factors. Like oftentimes teens will feel like responsibility to family members or friends or even pets, believe it or not. They may have some positive therapeutic relationships or other trusted relationships at school, or other social supports. So you want to really see if there are protective factors there and what they are. Okay, now here's the main piece. The suicide inquiry piece, okay? These are the main points to hit when you're doing a suicide inquiry during a suicide risk assessment with an adolescent, okay? You want to ask first about ideation, okay? Have you ever had thoughts about killing yourself? Yes, tell me about that. How often do you think about that? So you're getting at frequency. To get at intensity, you may ask, like, when you have the thoughts, how intense are they? Like you can do some scaling here, like from a scale of 0 to 10, like, how strong do they feel? Duration, so for how long do they last when you have them? So one thing that a lot of studies are finding is that it's this intensity and duration of the suicidal thoughts that are more predictive of whether or not an adolescent will actually attempt. So you really want to find out about that. It's not enough just to ask, are you having suicidal thoughts? That's not enough. You need to ask more. You need to be open and empathically curious about what is that like for you? Can you describe that to me? What does it feel like when you're having these suicidal thoughts? What's going on in your mind? Okay, you also want to ask, once you've kind of covered the ideation piece, you want to ask about prior suicide-related behaviors. So have you ever attempted suicide before? Have you ever tried to but stopped yourself? Have you ever tried to but someone else stopped you? And then by rehearsals, we mean, have you ever done anything to prepare to kill yourself? So like tying a noose or loading a gun or gathering pills. And you want to ask about non-suicidal self-injury. And one thing you can do too is you could say, have you ever hurt yourself? The way I assess for that is I'll say, have you ever hurt yourself without the intention to die? So like you're not trying to die by hurting yourself. And if they say yes, you want to ask about that too and really try to understand it. Okay. So now we get to the real meat, and the most important thing you can probably take away is once a teen has endorsed suicidal ideation to you, you need to ask about these three things: plan, access, and intent. Plan involves the timing, location, lethality, availability, and preparation. Okay. Access means, does the adolescent have access to lethal means? Do they have access to, what it is that they are thinking about doing to kill themselves? And intent, the extent to which the adolescent, one, expects to carry out this plan, and two, believes that that plan is going to be lethal, is going to kill them versus simply self-injurious. And you also, during the suicide inquiries, you want to explore the ambivalence of the teen, reasons to live versus reasons to die, and see if where they are on that. You know, for some of you who do substance use work, you're like, oh yeah, that's like, you know, decisional balance and motivation interviewing. Yes, it is. This it is. It's the same skill. Okay. So you want to get, just to go a little further into here, you want to get a really detailed, rich description of the current problem, get an idea of what the current symptoms are and their severity, suicidal behaviors, attempts, plans, notes, asking about that, asking about precipitating events, asking about stressors, acute stressors and chronic stressors, okay? So specific questioning. You want to ask about suicidal thoughts and prior suicide-related behaviors and intent as open and as frankly as possible. So sometimes I'll start with a question like, do you ever feel life isn't worth living? And see how they respond. And if they're, yeah, I have. Okay. Have you ever wished you could just go to sleep and not wake up? That could be another way you could start by asking. And if they're saying yes to this stuff, you can say, have you ever tried to hurt yourself wishing you would die? So again, we're not getting right at the direct questioning yet of, have you thought about killing yourself? But then this fourth one here, have you been having thoughts about killing yourself, either now or in the past? We want to ask really directly. So for some kids, you may feel like you need to ease into it a little more, but some kids you may be able to jump right to, have you been having thoughts about killing yourself? You kind of have to feel it out a little bit and use your own clinical judgment. But by the end of the assessment, you have to be asking the direct question. Have you ever tried to kill yourself? And then what did you think would happen when you, if they did try before, what did you think would happen when you, whatever they did? Because sometimes teens do it and they don't actually think they're going to die from it. And other teens do try something thinking they're going to die, and thankfully they don't, but they think they have full intent. They're trying to kill themselves. Other things you can ask them is, how do you feel about the fact that you survived your attempt? If the adolescent answers yes to any of the questions, you want to get at the who, when, what, where, why, and how of it all. You want to really be sitting with them openly, empathically curious about what it is, you're thinking of doing. How do you think you might do it? And when do you think you might do it? Where might you kill yourself? How might you do it? Why do you want to kill yourself? And then the last question, which is pretty key, is who knows about this? You may be the only person they've told. That happens sometimes. And I know that's a scary thing as a clinician, to be the holder of this scary, this information, but just know that means this kid is trusting you and that you are doing the right thing here, and you will be able to help them by getting them the help that they need to make sure that they're going to be okay. And of course, in schools, this always happens at about 3 o'clock, right when you're about to leave, usually. So I'm sure that's happened to a bunch of you on this call, workshop. All right, so let's talk more about this last one. I really want to drill this into everyone's head, because this is the most important piece, I think, of how to do a risk assessment. If a teen endorses suicidal thoughts, you always want to ask about plan, access, and intent. Okay, these are the questions I use. Feel free to put it in your own words, but these are the clear way. If they endorse a plan, you want to get the specifics. So you want to ask, do you have a plan of what you might do? And if they say yes, you want to say, tell me about it. What are you thinking? And they may say something like, well, I've been thinking about just overdosing on my antidepressant pills or something like that. Okay. If they say that, you're not done asking about plan. You then ask, what else? What other plans have you made? Okay. Oftentimes we think as clinicians, we just stop there with what they've given you. But what teens often do is they'll tell you the least lethal one first, just to kind of get you to stop asking. Okay. Or not even just that. Sometimes they test you out by giving you that one. But you want to keep saying, what else, what else, what else, until you've exhausted everything, all of their plans. Okay. You want to get at all the different plans. And because if you say what other ways, they could say, oh, none, that's it. Okay, good, done, move on. But if you never want to just assume that the first one they tell you is their plan. You keep asking. Then you want to ask about access, and you want to ask both parents and teens about access. Okay, you and the parents might be surprised if you ask the parent, you may ask the parent, do you have this happened to me once, any firearms in the home? Because you need to always ask about access to firearms. Always, 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 no matter, I don't care what state you live in. I don't care if you, whatever internal biases are going on in you when you're doing the assessment, you always ask every single person. I remember one time when I was doing psychiatric evaluations in the emergency department, a family came in and I had my own internal biases, assuming there was no guns in this home in Massachusetts. But I asked because that's my training. You always ask. And the kid said, yeah, my dad's a police officer. And he has a gun. And I just, again, was assuming in my head, well, why would she, he's probably locked them up, and they seem like a very well, very responsible family and that sort of thing. And I said, well, do you have access to it? Is it locked? And she said, well, it's locked, but I know the combination. And that right there changed my entire assessment, because me thinking this kid, and she had very low level of suicidal thoughts, but if you have a firearm in the home and you have one fleeting thought and you act on it using a firearm, you will most likely die. So we need to be really careful when we do those types of assessments. So really ask about firearms, and make sure you ask both the parents and the kid separately. The kid also, the parents may say, well, yeah, we have guns, but they're upstairs and they don't know where they are. But then you could ask the kid and say, yeah, my parents have a gun collection upstairs. You have to ask both. Don't just assume one knows. The other thing I ask people too is, I don't ask, do you have a gun in your home? Because a lot of kids don't have a gun in their home, but they know how to get them. So I instead ask, do you have access to a gun? I ask it like that. Like, are you able to get a gun if you wanted to? Because kids can find guns from other people. The kids know who have them. So just make sure you're asking like that. Also with access, you want to ask about access to all the plans they list. So if they list, I was thinking about hanging myself, then you would say, do you have access to the things you would use to hang yourself? And you want to get that information. And you want to hear, like, how far are they thinking ahead about this stuff? Like, are they thinking through it? You want to ask about access to every single plan that they endorse. Okay. Now, this last one, intent. You need to find out about suicidal intent, because there are a lot of kids who have a plan and access, but have zero intent, and which is great. But there are also a lot of people who have kind of so-so plan and access, like kind of iffy, but their intent is really strong. So you have to be careful of that too. The way I assess for intent is I usually kind of explore plan and access for all these things and really kind of understand them and what the kid's thinking about it. And then I'll say, so is this something you think you might actually do? And then you listen to how they respond to that, and you can do further inquiry there if indicated. Okay. Step 4, that's determining risk level and intervention. So this is difficult to know what to do and how to, what to do after you've done the assessment. So I find that the high and the low are pretty, and I won't go into this too much in depth, because I'm thinking, the majority of you are not, are school social workers or learning more about school social work. So you wouldn't have to necessarily determine this, like whether or not someone needs to be psychiatrically admitted. But just know that for the low end, that's often if you see someone with a lot of modifiable risk factors and really strong protective factors, and they may have thoughts of death, but no plan or intent or prior behaviors. But kids like that should really be seeing a therapist. So you want to make sure as a school clinician that you are connecting them with outpatient referrals, and make sure you have the emergency numbers they need in case future crisis does emerge. The high ones are also sometimes can be relatively easy to do. If they're, if there's a potentially lethal suicide attempt, you find out about at the school, and they're still having really strong ideation and intent. This is a kid who likely needs admission to psychiatric admission. So then you need to get them to an ER as soon as possible for an evaluation. And you're going to need to know too, which are the ERs that have, you want to make sure they're being evaluated at an ER that is connected with an inpatient unit. Otherwise, they could be sitting there for so long. And right now there's a huge boarding crisis where kids are just sitting in emergency departments, which is also the case why if there's a kid at moderate risk, inpatient psychiatric care isn't always the answer, okay? There's actually no evidence saying that it is best practice to have a kid hospitalized psychiatrically if they have suicidal thoughts with a plan but no intent or behavior. That is not, inpatient psychiatric hospitalization isn't necessarily the best treatment for them. So this is kind of beyond the scope of this talk, but there are other options. And when you do have a kid in that moderate range, those are really the toughest cases to be able to know how to help. Okay, documentation. I can't say it enough. You have to be as clear and concise in everything that you've talked about, because this is, if there's a medical record, I think a lot of schools have these. Some private schools do. I don't know exactly which schools what the records are, but you need to make sure that you've documented what you've asked them and how they've responded as they relate to the suicidal inquiry. Okay,